Hey everyone, and welcome back. To all our AR associates tuning in, welcome to part 12 of our Revenue Cycle Management training series. I'm your trainer, Harshel, and today we're diving into what is honestly one of the most common, but also kind of the most misunderstood roadblocks in medical billing. We are talking about non-covered service denials. More specifically, we're going to completely master the difference between a PR96 and a CO96 denial code. Now, if you've ever stared at a remittance advice and just thought, wait, do I bill the patient for this or do we write off the balance? Well, you're absolutely in the right place. We're going to build a rock-solid diagnostic framework together today so you can confidently resolve these accounts every single time. So let's quickly take a look at our roadmap for today's explainer. We'll start with an overview of non-covered denials, then move into finding the root causes, checking out the step-by-step resolution workflows, reviewing some standard AR caller notes, and wrapping it all up with a quick knowledge check and review.
All right, jumping right in. Section 1, Overview of Non-Covered Denials. Let's get a really clear definition of what these actually mean when they pop up in our queue.
Okay, so this is where we hit a massive fork in the road for your entire workflow. Both of these codes, PR96 and CO96, deal with non-covered charges, right? But the two letters at the front dictate exactly who is left holding the bag. PR literally stands for patient responsibility. A PR96 means the service simply isn't a covered benefit under that patient's specific health plan. CO, on the other hand, well, that stands for contractual obligation. A CO96 means the service isn't covered because of the specific contract your healthcare provider signed with the payer. So the absolute crucial takeaway here is this. PR means the patient might have to pay out of pocket, while CO means the provider's office might just have to absorb that cost or fight the denial. Moving right along to Section 2, finding the root causes. Because, before we can actually treat the denial, we have to diagnose exactly why the payer categorized the service as non-covered in the first place. There are a few pretty standard triggers for a 96 denial. For patients, their specific plan might just strictly exclude certain procedures. Think things like cosmetic surgery or experimental treatments. Another really common trigger, out-of-network services. If a patient has an HMO or EPO plan, those plans typically do not cover out-of-network benefits at all, and boom, that leads straight to a PR96. Now, on the provider side, the contract they signed might have what we call scope limitations. Basically, the payer is saying, hey, based on your specialty, you actually aren't contracted to bill this specific code. And finally, sometimes it's literally just a coding issue. The diagnosis code just doesn't medically match the procedure code, which causes the system to automatically flag it as non-covered. All right, Section 3, Step-by-Step Resolution Workflows. Let's get into the nitty-gritty of how to actually fix these. So, let's say you see a PR96. Your main goal here is to confirm if the patient truly owes the money. Step 1, and this is absolutely crucial, always review the claims history. Has this exact CPT code been paid by this payer for this patient before? If the answer is yes, then the payer actually made a mistake. You need to get them on the phone to reprocess it. Step 2, verify the plan type. If it's an HMO or an EPO and your provider is out of network, well, the denial's probably correct. But if it's a PPO or a POS plan, they usually have out-of-network benefits, so you'd send that right back for reprocessing. Step 3, always check your billing system to see if they have secondary insurance. And finally, Step 4, if the denial is totally valid and there's no secondary payer to bill, that's when you shift the balance and bill the patient. If you think of this process like a giant decision tree, the very first question you have to ask yourself at the very top is, were similar services paid previously? That is your first major checkpoint. If the answer is no, then you split off based on the code. Is it non-covered as per the patient's plan or the provider's contract? If it's the patient, you go down that path of checking for secondary insurance before finally landing on the decision to bill the patient. Keep this logical flow in the back of your mind. It's a real game changer. Now, let's flip the script and look at the CO96 workflow. Notice something big here? We are not checking for secondary insurance, and we are absolutely not billing the patient. No way. Step 1 is pretty much the same, though. Check the billing summary. See if the provider was previously paid for this CPT code. If they were, call to reprocess. Step 2, route this straight to your coding team. Often, a CO96 just boils down to a coding error. Step 3, if the coding team comes back and says, nope, the codes are 100% correct, then you've got to initiate an appeal with medical records to fight that denial. And finally, Step 4, if the appeal fails, or if you find out it's a hard contractual exclusion, you escalate this for a provider write-off or adjustment. In this scenario, the provider takes the hit, not the patient. Let's move into Section 4, Standard AR Caller Notes. We all know that resolving an account requires perfect documentation, so let's look at exactly how to record these scenarios. What we have here is a pristine, standardized template for a PR96 denial call. It literally covers every single base. You start with the data service and the billed amount. You state exactly who you called and what they confirmed, like in this specific case, an HMO out-of-network limitation. Then, and this is so crucial to your quality score, you document that you actually checked the billing summary for previous payments and checked for secondary insurance. Finally, you explicitly state your concrete action, bill to patient, followed by your claim and call reference numbers. It's clean, it's concise, and it leaves zero room for confusion. And conversely, here's how you document a CO96. Again, start with the date of service and the billed amount. You note that the rep confirmed the provider is not eligible to bill the CPT under the contract. You document that you checked for prior payments, but look closely at the action steps here. Sent to coding team for review. Coding confirmed correct. Action, appeal submitted. Or, if an appeal just isn't an option, that action becomes provider write-off. Notice how the documentation perfectly mirrors the workflow we just talked about. It tells the whole story. All right, Section 5, Knowledge Check and Review. Let's see how all this theory builds into real-world application with a quick quiz. Question 1. Think carefully about the workflow we discussed. If a claim is denied as PR96 because an HMO plan does not cover out-of-network services and there is no secondary insurance on file, what is your final action? Is it A, write-off, B, bill the patient, or C, appeal? Take a second. Moving to question 2, let's test those definitions. Which reason code represents a non-covered charge specifically as per the provider's contract? Is it A, PR96, B, CO47, or C, CO96? And our final question. Before you package up a CO96 denial and send it off for an appeal to the payer, which internal team should absolutely review the claim for accuracy first? A, the coding team, B, the patient, or C, the data entry clerk? Let's see how you did. For question 1, the correct answer is B, bill the patient. Since it's a PR code with no secondary insurance to fall back on, that balance becomes the patient's responsibility. For question 2, the answer is C, CO96. Remember, CO stands for contractual obligation. And for question 3, the answer is A. Always have your coding team verify the CPT and diagnosis codes before you waste precious time appealing a claim that might just have a simple data entry error. You guys have done an absolutely excellent job today, mastering the vital differences between patient and provider non-covered denials. Knowing when to confidently bill the patient versus when to route something over to coding is going to make you an incredibly efficient AR analyst. So keep utilizing those decision trees, keep your notes crisp, and keep pushing your skills to the next level. But I want to leave you with this to chew on. As patient insurance plans become increasingly complex with all these hidden network limitations, are we headed toward a future where PR96 denials become the absolute #1 cause of lost hospital revenue? It's something to think about. Stay ahead of the curve. Share and subscribe for free courses on Decode Healthcare with Harshal.